Hello, welcome to the EKG Guy and welcome to the EKG of the week. I hope you're having a great week and I'm glad you could join us. This week's case is a 55-year-old female that is recovering from a respiratory infection. She also just finished her last dose of azithromycin and is feeling much better today. Her EKG is shown here. Before we get started, let's review the approach we've been using to interpret EKGs. So notice that we have the patient's clinical presentation and then the EKG below. On the right side of the screen, we have the list that we'll go through before making our interpretation. First, there is the regularity of the rhythm. That is, are we dealing with a regular or irregular rhythm? And if it's irregular, is it regularly irregular or is it irregularly irregular? Next, we have the heart rate. Okay, so we'll determine that. Then the rhythm origin. That is, where's the rhythm actually starting from within the heart? Then there's the atrial AV, or atrioventricular, and intraventricular, or IV, conduction. There we're going to be looking is the conduction normal or not in those locations. Then we have the waveforms, and this will include all the waves, all the segments, and the intervals. And lastly, is there anything else? Meaning, is there something that we're missing or still need to mention? After that, we'll use all this information that we've gathered to make a final interpretation of the EKG. Now, I want you to pause the video and take a few minutes to go through it yourself. When you're ready, start the video and we'll take a look at this. Okay, so we have a 55-year-old female recovering from a respiratory infection and finished her last dose of azithromycin, and she comes to us with this EKG. So first, let's start with the regularity of this rhythm. Well, on first impression of the EKG, you probably noticed that the rhythm appears quite regular. In fact, this is a regular rhythm, okay? So this is a regular rhythm, and let's see why that's the case. Well, remember, when we're looking at regularity, one of the easiest things to do, and what you can see by looking at the EKG, are these QRS complexes really stick out, okay? And when we look at regularity, we're looking from one R wave to the next, okay? You can do this with other intervals, but this is the easiest. So we're looking at this R to R interval. We're seeing if that R to R interval continues to be the same throughout, okay? So from the next one and so forth, all right? Meaning that is that distance, that duration, the same throughout. And if you were to measure that out using your calipers or a piece of paper, you'd see that that's the case here, okay? And that's why we call it a regular rhythm. So what did you get for the heart rate? Well, there's a couple ways we can calculate the heart rate here because we're dealing with a regular rhythm. So first off, I'll give you what the heart rate was, okay? It was 76 beats per minute, okay, that they recorded, and let's try to figure it out ourselves. So knowing that the EKG represents 10 seconds, meaning this whole duration here is 10 seconds. So if we multiply 10 seconds by 6, we get 60 seconds. 60 seconds in a minute gives us the number of beats per minute, okay? So what we do is count the complexes going across the EKG, we multiply that by 6, and then that should give us the beats per minute, okay? Or in 60 seconds. So let's try that. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. Okay, so 13 QRS complexes going across. So 13 times 6 is 78 beats per minute. Okay, and that 78 is close to the actual 76. All right. Now, because we're dealing with a regular rhythm, there's also another way we can do this, okay? And that's by locating an R wave that falls on one of the thick lines, okay? So we can use this one. Notice it falls on that one. And we're going to count the number of thick lines until the next R wave. So here's our next R wave, okay? And the number of thick lines between it is 1, 2, 3, and it's 4, okay? So there's 4 thick lines between it. So you do 300 divided by 4, and that gives you 75 beats per minute. Okay, so 75 and 78 is what we got. The actual one is 76, so that's quite a great estimate that we got. Okay, so regular rhythm, heart rate about 76 beats per minute. So moving on, we have the rhythm origin. Well, we have narrow QRS complexes, so it's likely a supraventricular origin. Okay, what do we mean by supraventricular? That means it's originating above the ventricles. Okay, so it could be coming from the AV node, a junctional rhythm, the atria, or the sinus node. Now we can also make out clear defined similar shaped P waves here, so we should look to see if we're actually dealing with sinus rhythm. Okay, so how do we know if we have sinus rhythm? So notice our P waves, they're smaller here, but we can make them out. Okay, this is a P wave. Here's another one. Okay, lead 2, we can see them as well. And you can see them here in AVF. All right, and we want to see them in leads 1, leads 2, okay, even AVF, some of the inferior leads, and also in those lateral leads, so V4, V5, and V6, okay, so here's a P wave upright, another one, and so forth, all right, and they all look the same. And then if you look at AVR, we can see that inverted P wave, okay, and we want to see inverted P waves there. Now remember, if we were to draw our heart, okay, as this diagram, we know this is our right atrium, our left atrium, right ventricle and left ventricle. Our sinus node starts here. We have these internodal pathways, a Bachman bundle that comes to the left side. We have our AV node that comes down into our His bundle, splits off to the right bundle branch. Then the left bundle branch that goes into a left anterior and left posterior fascicle. Okay, and why we say it will be heading in this direction, or we'll see it in those leads. So let's put our leads here. Okay, so imagine this is our sinus node, okay, and if things are firing, it's going to be heading in this direction. So if we use this, it would be heading in this way, all right, and where lead 1 would sit would be right here in our frontal plane. This would be AVF, okay, AVR is here, okay, and then we can also add lead 2 here, lead 3, okay, as well, and then we can add some of our precordial leads, V4, V5, and V6, okay? So notice that we have this wave, this electrical axis, our P wave heading in this direction. It actually goes between 0 degrees and positive 75, okay? So if we have that depolarization wave heading towards those leads, we should see upright P waves in these leads here, okay? And because it's heading away from lead AVR, that's why we see the negative P wave in that lead, okay? So hopefully that makes sense. All right, so we have upright P waves that are similar in morphology in those leads and inverted in lead AVR. We should also see in sinus rhythm that there's one P wave for every QRS, okay, and that the P wave comes before each QRS complex. All right, so what do we mean by that? Well, let's just erase some of this here so we can take a look. All right, so again, here's a P wave, and then our QRS, a P wave, QRS, P wave, QRS, okay, P wave, QRS, okay, and you could see that as you go throughout the whole rhythm that you have one P wave for every QRS complexes. All those P waves have the same morphology or configuration, and they are all upright and inverted in those leads, okay, and that's why we say we are dealing with a sinus rhythm, okay. The rhythm is originating in that sinus node up here, okay. So how about atrial conduction? Well, typically we look at leads 2 and lead V1 for the P waves, okay, or atrial abnormalities. And if we look at V1, they're there, but they're more evident in lead 2, okay. So V1, you can somewhat see them there, all right, present there, but really in lead 2 we can see them. We already kind of highlighted them, all right. And you can see them there. And what we're looking for here is that the P wave duration should be within normal limits, okay? And the duration should be less than 120 milliseconds, or less than 3 of those small boxes, okay? And we do see that here, all right? So we have normal atrial conduction. Next, we look at atrioventricular, or AV conduction, and in this case, we're looking for the conduction delays as the impulse travels between the atria and ventricles. And because the majority of the PR interval represents AV nodal conduction, we're going to take a look at that area there, okay? The normal PR interval in adults should be between 120 and 200 milliseconds, or 3 to 5 small boxes, okay? And remember, in children, as they're growing up, it tends to be shorter, and as they get older, to the adult range, we see that 120 to 200. Okay, our patient here is 55, so obviously an adult. Now here the PR interval is actually on the short end of normal. Okay, we said that it's 120 to 200. It's actually 112 milliseconds here. Okay, so as you can see, that's below that 120 range. And remember, when we look at the PR interval, so imagine this is our P wave, this is our QRS complex, this is our T wave. PR interval includes the P wave up until our QRS complex. We call that the PR interval. PR segment, on the other hand, is from the end of the P wave up until the beginning of our QRS complex. So different, okay? PR segment plus P wave equals PR interval. That's one way you could think of it, okay? And we're saying that this P wave, or this PR interval, okay, is somewhat short. So if you look here, use our rhythm strip here, and here's a P wave, okay, and then we have our QRS, so it'd be from there to there, little hard to make out, but you can see that that is clearly below the 200 milliseconds, or those one of the thick lines. Okay, so it's within normal range, but still it's on the shorter end. It was actually measured at 112, we said. Okay, so we would consider that kind of like the short normal. All right, and we'll see why that's the case. All right. Now, we really don't get too suspicious of pre-excitation syndromes, right? With these short PR intervals, we start to think of those, such as with Wolff-Parkinson-White syndrome or Longenau-Levine syndrome. And usually we don't think of those until we get around 110 milliseconds or below and the patient is symptomatic. In addition, WPW syndrome has a prolonged QRS interval with that characteristic delta wave, okay, which we don't see present here. And we'll talk about that soon, how our QRS intervals are actually normal. With Longenau-Levine or LGL syndrome, you actually have narrow QRS complex, but again, this is less likely the case based on our clinical context with this woman. Now, some other conditions to keep in mind on your differential when you think of this short PR interval should include a junctional or low atrial rhythms, okay, meaning it's coming from somewhere here in the atria. Now, some other conditions would be glycogen storage disease, Fabry's disease, pheochromocytoma, hypertension can cause it, or simply a normal variant, okay, and it's that normal variant that's likely the case here. Okay, so again, short normal for the AV conduction. We're not too concerned with it. Okay, she's asymptomatic and doing fine. So next we have the intraventricular or IV conduction, and here we look at the duration of the QRS complex, or that QRS interval, and normally it should be between 80 and 110 milliseconds, or 2 to 3 small boxes. Okay, the main thing we're looking for here is for intraventricular conduction should not be prolonged anywhere. Okay, so really you don't really need that lower limit, but again, we're looking for something that's not prolonged, so we're not dealing with any intraventricular conduction delay. Now we can see narrow QRS complexes that appear within normal limits here. Okay, our QRSs here appear quite normal. In fact, they're actually the duration of them. So when we're looking at the duration, we're looking from the beginning of our QRS to the end. Okay, and here the duration is actually 74 milliseconds. Okay, we mentioned that 80 to 110, so we're saying this is slightly below our normal range that we mentioned, but again, certainly not prolonged, so we consider this IV conduction to be normal. Okay, so this was still normal. Okay, now we have the waveforms. Now we said the P waves were normal, okay, no problems there in lead V1 or lead 2. The T waves here are present, they're asymmetric, and they appear normal. Generally, the T wave amplitude decreases with age and tends to be lower in females than males, okay? And we actually see that here. Generally, we consider abnormal T waves if it's less than 10% of the R wave amplitude, and it's actually easiest to see the T waves here in lead V3. Okay, so here's V3, and here's our T waves. Okay. And V3 is one of the leads that they tend to be the most prominent. Usually V2 and V3 are the most prominent that we see the T waves. And on average, in women, adult women, they tend to be between 0.3 and 0.4 millivolts. Okay, you can see them up to 0.8 or 0.6, but generally we're looking for 3 to 4 millimeters, which is 3 to 4 small boxes, okay, in amplitude. All right, and we see that here. They're normal. Okay, so nothing to be concerned here. Now, some may consider the smaller or difficult to make out T waves as non-specific T wave abnormalities, but in general they appear within normal limits in our case here. Okay, so we showed the T waves here. Okay, you can somewhat see them here. Notice that you can see that there. All right, and throughout the EKG, you know, it's hard to make them out. Okay, so some, like I said, may consider that a non-specific T wave changes. But really, it's normal in this case. Okay, so we're not going to be too concerned at this point. Now, how about the PR segment? Okay, it's not significantly depressed or elevated. The PR and the QRS intervals we said were within normal limits. The QRS amplitude appears normal. Okay, so no evidence of hypertrophy here. The ST segment does not appear significantly elevated or depressed anywhere. The QT interval appears to be a little difficult to make out, and that's because of those small T waves that we mentioned, but we can still see it here in V3, V4, and AVF. Okay, so remember when we look at the QT interval, okay, we're taking from this point here up until the end of that. That's what we consider a QT interval. All right, and we mentioned here in AVF, here's our T wave, you can see that there. Okay, that would be our QT, and then we can also see it in V3, right, where our T waves are the most prominent from the beginning of our QRS to the end of that T wave, and also in V4. Okay. So again, within normal limits, usually we're looking for something less than 460 milliseconds, and we see that here. Okay. Now, if you recall, we mentioned that this lady is finishing her treatment of azithromycin, which is a macrolide, and this has the potential to prolong the QT interval and has that risk of torsades, all right, that can be quite lethal. So that's just a side note to keep in mind. Remember, the clinical context is key and will direct you towards what we're looking for on the EKG. So that's one thing to be aware of, that clinical context, respiratory infection, coming off some antibiotics, so look out for that. So anyways, there's no major waveform abnormalities here, all right? So again, we can write normal, all right? So is there anything else we're missing? Well, not that I can see. You may see something and let me know if I'm missing anything. But the ventricular or QRS axis, if you found that out, is actually normal here. Generally, there's a normal R wave progression in those precordial leads, okay, that we see. And also, there's somewhat of a wandering baseline at a few points in this EKG. So wandering baseline, notice it here, right? Our baseline is flat and then it comes up and slopes up. Same thing here. And then a little bit at the end, all right? Now, in terms of our ventricular axis, let's just look at that here. Okay, so if you recall, when we look at the ventricular axis, we'll simplify by looking at leads 1 and AVF. Okay, this is the positive end of both leads. Here's 0 degrees. This would be positive 90 degrees, plus or minus 180 degrees, negative 90 degrees. Okay, and we're going to be focusing on leads 1 and AVF. Okay, so if we look at, let's take lead 1 first. Okay, slightly, mostly, it's definitely positive, so we'll head towards the positive end of that lead. If we look at AVF, again, positive, so we're heading towards this way, and we're in this range, all right? So is that normal or not? Well, that is certainly normal. This is considered the normal quadrant. This would be left axis deviation, right axis deviation, okay, an extreme right axis deviation. Now remember, in adults, first of all, in children and infants, we tend to see the axis in this range, okay, and eventually heads this way, more leftward, okay, and as we get older, it heads that way. So normally in adults, it's from negative 30 degrees, okay, to positive 105 degrees. So certainly we're within that normal range. So we have a normal QRS axis, okay. We also mentioned that wandering baseline. Okay, and then we also mentioned normal R wave progression. Okay, and let's just look at what is that normal R wave progression. Okay, so let's erase some of this here so you can just see what I'm talking about. All right, so normal R wave progressions means the R wave, remember this is our R wave here. Okay, this portion here, it's the R wave is defined as the first positive deflection after the P wave. Okay, so we can see a small R wave there. Here's it's getting a little bigger there. Okay, these are our R waves. Okay, and so forth. So what you normally want to see is as we go across the precordial leads, so from V1 to V5, we want to see the R waves increase in amplitude. Okay, meaning that they're getting greater. So notice this is the R wave. It's getting a little bigger, bigger, and so forth up to V5, okay? And if you see that as a normal R wave progression, they seem a little small in the right precordial leads V1 and V2, but really nothing significant. No deep S waves in the left lateral leads, so not really anything we're too concerned of. So I would generally say this is normal R wave progression. Okay, so what's our final interpretation? Well, we have a regular sinus rhythm, okay, occurring at a normal rate. So regular rhythm, normal rate that we said around the 76, 78 beats per minute. We have normal AV, atrial, AV, and then IV conduction, okay? And we said there's no major waveform abnormalities. So despite all these nuances that we discussed with the short PR interval and those T waves, this is still a case of normal sinus rhythm, okay? All right. So in conclusion, our 55-year-old female recovering from a respiratory infection has an EKG that shows normal sinus rhythm. Well, that's the end of this week's EKG of the week. I hope you learned something. Please don't forget to like this video and leave a comment below if you like what we're doing. In fact, many of you have asked how you could help us out. Really, the best way would be to simply subscribe and share this resource with your friends. You get free access to more than 300 videos, including both pediatric and adult courses, something I wish I had when I first started. There's also a community of over 100,000 of us like-minded individuals on Facebook, so stop over and join the EKG Guy's Facebook community. Lastly, your feedback is incredibly helpful, and your kind words are always an encouragement on those long days. Thank you again for your support. It is truly appreciated. We're the largest, fastest growing EKG resource in the world.